have three speakers with us today. Charity Heding is a master's level social worker licensed as an LICSW. She's worked in inpatient and outpatient settings, providing therapeutic services. Charity has additional training and certifications in specific trauma-related treatments to include a certification as a complex trauma professional level 2, trauma-focused cognitive behavioral therapy, and eye movement desensitization and reprocessing, or EMDR. Kacci Ratliff is our next presenter, who is a licensed professional counselor and a national certified counselor. She completed her master's degree in clinical mental health counseling at Waynesburg University in Pennsylvania. She's got 6 years of experience across a variety of settings, including substance abuse inpatient programs, substance abuse outpatient programs, crisis intervention, and inpatient psychiatric settings. She utilizes a variety of techniques in the treatment process that are tailored to the individual, including motivational interviewing, cognitive behavioral therapy, person-centered therapy, mindfulness, and 12-step work. And last but not least, we have Elizabeth Young, who is a WVU School of Social Work alumni and got both her BSW and MSW here. She is an assistant professor with the School of Medicine, Behavioral Medicine, and Psychiatry, currently works at William Sharp Junior Hospital, and has over 28 years of experience in inpatient mental health social work. Her focus is individual and group therapy with individuals who experience psychosis. So welcome to all our speakers. I'm going to turn it over to you guys. And one final thing, if folks have questions, you can feel free to post them in the chat throughout the seminar, and Sarah and I will be monitoring that. Sarah's my GA, and periodically taking breaks for questions. So that's all I'm going to say, and I'm going to turn it over to our speakers.
Thank you very much. So today we get to be talking about considerations in working with adults with trauma. And as you can see on the slides there, all the slides will have a background on them of the water droplets. And that's just a reminder that that little droplet of trauma, no matter how small it might be for someone, can cause a major ripple effect in their life, but it can also be major traumas that happen for people and have impactful moments in their lives as well. So when we talk about trauma, we're talking about trauma according to the American Psychological Association as trauma is an emotional response to a terrible event. Trauma can occur once or on multiple occasions, and an individual can experience more than one type of trauma. For the prevalence of trauma, we have from the Ratliff Institute for Traumatic Stress Disorder from their fact sheet, an estimated 70% of adults in the United States have experienced a traumatic event at least once in their lives, and up to 20% of these people go on to develop post-traumatic stress disorder or PTSD. An estimated 5% of Americans, more than 13 million people, have had PTSD at any given time. And approximately 8.7% of all adults, or 1 in 13 people in this country, will develop PTSD during their lifetime. About 3.6% of adults in the United States suffer from PTSD during the course of a year, and an estimated 1 out of 9 women will get PTSD at some point of time during their lives. Women are about twice as likely as men to develop PTSD. And some additional statistics that we have is from the VA National Center for PTSD regarding the US population. About 6 in every 100 people, or 6% of the population, will have PTSD at some point in their lives. And about 12 million adults in the US have PTSD during a given year, according to their statistics. This is only a small portion of those who have gone through a trauma. Not all those who have gone through a trauma are going to qualify for a PTSD diagnosis, but it doesn't mean it's not something that needs to be assessed and treated possibly. About 8 out of every 100 women, or 8%, will develop PTSD at some time in their lives, compared to about 4 in every 100 men, or 4%. So, and I included the links to each of those statistics if you would like to see them when you get the slides in your presentation as well. So part of our main focus for the presentation today is talking about why assessing for trauma is important and why treating trauma can be important, and some considerations that you might want to factor into treating and assessing for trauma. So when we look at assessing for trauma, we are doing it not only for proper diagnosis and for ethical treatment of our person that we're working with, which is a major factor across the board. And as we'll look at, trauma has a major impact on diagnosing and can overlap multiple diagnoses or cause and trigger multiple diagnoses as well. But if we're missing assessing for the trauma aspect, we are missing a large portion for our person potentially. Also, assessing for trauma, we are working on treating the whole person, not just a list of their symptoms or their list of diagnoses, but we want to make sure that we're treating them as our person in front of us. Many of the symptoms that are caused by trauma can present as other diagnoses if trauma isn't factored into the differential diagnosis. And we'll talk about how misdiagnosis can occur rather easily as well. Trauma also impacts areas of the brain and different chemical releases, and therefore it impacts the functioning of our individuals we're working with. So if you're missing assessing for and then treating for trauma, you're possibly not properly treating the person that you are working with. So we really want to make sure and put an emphasis on assessment and assessment throughout the process of working with someone. It's not just a one-time initial assessment that we do or a yearly assessment that maybe an agency requires of us. This is something that is an ongoing assessment for our person. And that's not just because a trauma can occur at any point in someone's life, but also because as we're working with someone, they may become more comfortable in working with us and build that rapport with us, where they feel more comfortable telling us that if something has happened for them that they consider a trauma. So that's why we want to make sure we're continually opening up that door for them, not trying to continually ask one single question about have you experienced a trauma, but just talking with their person in general and making topics approachable to be talked about if they have that available to them. When I've talked with people, they've brought up possible hesitations or concerns when we've talked about assessing for a trauma. So some of those things that people have brought up to me, and it could be different for each person, is that the clinician or the staff who's talking with their person is uncomfortable or uncertain what to do if someone brings up that they have experienced a trauma in their lives. And that uncertainty can be, just kind of in what's response to give someone, or, being afraid that it may impact them and lead to those possibilities of vicarious trauma for themselves, or being uncertain of do they need to report depending on what is being told to them. And so they'll sometimes avoid asking those questions, or maybe only ask it lightly and try and move on as quickly as possible. We can also find that it's not always the person's or the clinician's area of expertise, so they feel like that they don't know what to necessarily do from there. So if they open it up and ask the question and then they just leave it, that they're not really helping their person. So we'll talk about that too. And I will always encourage people, and you'll hear me repeat it a lot in this presentation, that if you are doing any diagnosing or any working with a person, you should be consistently assessing them as an ongoing process. Some people have told me too that they can feel like they're opening a can of worms if they ask about or try and get to if somebody had some trauma in their lives, that it can be just this huge topic and issue that they just can't seem to stop and get them to not be talking about. And they don't even know how they would end that conversation or that session with somebody. So that can be a difficulty as well. Some people have brought up to me that they're concerned that the person or client that they're working with won't be able to handle the question if they bring it up to them. And a lot of times we find that people are much more resilient than we necessarily will give them credit for. And when I'm talking with people and I ask them about their traumas, depending on where I'm assessing them to be at, I also give people, and I do this at the beginning of my assessments too, I give them an out always of being able to tell me if they're not feeling comfortable with answering that question today, and they can just let me know that. And it's a question I can always ask them again another time. So that way they don't feel like they have to tell me a mistruth and that they have to lie if they don't want to talk about it, but they can have an opportunity to tell me maybe another moment when they feel more comfortable. And I usually just make a note to myself to circle back to that another time. People have also brought up that they have concerns if they would need to report something and that process within that, and or what things they would not have to report. And especially in working with adults, sometimes there's questions with that if somebody is a vulnerable adult, or if there's questions of if they will be able to make their own decisions regarding reporting concerns, or how long ago things have maybe occurred for them. And I always encourage people, if they have concerns about if they need to report something, they can always seek out their supervisors, but they can also always call and ask the hotline, or, when in doubt, you can always report and find out, if they need to go further with an investigation, because that part is not for us to be deciding if an investigation is necessary or not. So assessment itself is not just about diagnosis. So an accurate diagnosis is a necessary portion, and that is something we do in order to get to an accurate diagnosis the best that we can. And then it is how we get to hopefully ethical treatment, proper treatment for our person. And just some of the diagnoses that they look at is if somebody has maybe a PTSD diagnosis or an acute stress disorder diagnosis. People may only qualify for an adjustment disorder diagnosis, depending on the time frame or depending on the event itself. And diagnoses are important because they help us get to leading to our treatment, and they can also help us regarding billing purposes and things like that. And it helps us identify for one provider to another of what might be going on for that person when we give a diagnosis. But the diagnosis is not the end of things when we're looking at doing assessment. So other related things that we might look at when we're doing diagnosing is if there was trauma related and there's now an attachment disorder that's present or has been present. Maybe there's major depressive disorder that was triggered as a result of some trauma that they experienced, or a generalized anxiety disorder. They find there's a lot of basis for individuals to develop borderline personality disorder, especially if there was a significant history early in childhood. They're seeing more of those factors play into that diagnosis. And they find that if we're able to work on and treat a lot of the trauma, that some of their symptomology will decrease in time too. It can be a lot of work though as well. And also people will consider bipolar disorder or any other issues, also attention deficit hyperactivity disorder, ADHD. ADHD can also, especially in children, be easily misdiagnosed if we're missing out on assessing for that trauma factor. I also encourage people to consider looking at, if they are going to be treating trauma, especially to be looking at the dissociation symptoms that could possibly be occurring, and look at the importance in the assessment related to that. So if you are doing specific trauma related treatment, you really should be focusing on and getting additional trainings as well. And in those trainings is where they will talk further about any dissociation type symptoms or assessments related to that as well. So trauma can be considered for an individual if the events or the experiences are outside of a person's ability to cope with the situation. So again, trauma does not mean that it has to qualify for a PTSD or trauma-related diagnosis in order for there to be treatment. If the event is an event for the person where they're feeling that it was outside their ability to cope and it was a trauma for them, we should talk with them about if treatment is a necessary thing for them or a needed thing that they would like. This does not mean that the individual will qualify for a diagnosis at any point during their time, but we do need to assess if treatment is appropriate for them. So assessment can also be impacted by other occurring diagnoses and vice versa, especially as we'll talk later on about substance use and psychosis and how those factors play into our assessment. So you'll be hearing from Casey and Elizabeth on that. And again, I always will continually reiterate throughout all of this that assessment is going to be a never-ending process during services, and assessment for trauma should be continually part of that process that we look at as well. So for different types of assessments, when we're talking about formally assessing specifically for trauma, there's wonderful resources available, and some of those are listed here. So there is the National Child Traumatic Stress Network, so the NCTSN. They have a wealth of resources and even additional sites that will lead you to trainings or even videos on different sources as well. And they can be very helpful, and they even talk about how trauma impacts a person as well. So their website can be a wonderful resource to look at. The VA's website, they have done a lot of research and assessments and treatments. So they have a great deal of information as well. So their link is there. And they will also provide links to their trainings for any types of assessments or screenings, or if there are specific trainings needed for specific assessment tools, they will usually provide you the link for that as well, if that was something you're interested in learning further about. The APA has a section as well where they talk about their PTSD assessment guidelines and different tools that they recommend utilizing. And they usually will, I believe they still link back to the VA's website as well. So each of these sites will have further information on trauma assessments and tools and training for utilizing these assessment tools as applicable. Specifically, going through and doing a trauma assessment can be helpful, but it doesn't mean that you are needing to assess a specific assessment tool for every person that you see. That is part of going through and doing your initial assessment and seeing which direction you're needing to go for an individual. So, and each additional trauma training will have additional assessments that they recommend. So if you are going through TFCBT or EMDR training, they will go through their tools that they are recommending in the course of how to utilize them and why to utilize them as well. So again, assessment will be a continual process throughout the course of care for an individual. So some of the treatment considerations that we look at is that there's multiple different types out there that are evidence-based and some that are growing in their evidence base. Some of them that are out there currently that you can get easy trainings on is trauma-focused cognitive behavioral therapy, which is TFCBT. There is eye movement desensitization and reprocessing, or EMDR. There's prolonged exposure, or PE. And cognitive behavioral therapy has a base with they utilize for trauma, and they have a manualized approach that you can utilize. And there is also cognitive processing therapy, which is utilized a lot by the VA system, but it is very helpful, also manualized program. There are additional medical-based interventions that are available as well, and I included a link to just one type. The VA has done a lot of research and has been finding some helpfulness. So for individuals that maybe doing your traditional or even any form of therapeutic intervention isn't their right answer, we should look at what our other answers are too, from either medically based or if there's any medication assistance that they could be utilizing to help out with their symptomology too. So the VA has done some wonderful work towards that, and you can usually see their information if you just Google it, but their link is there as well. So there's many other possibilities, but I will encourage everyone to make sure that if they are doing any trauma-based services, that it's an evidence-based practice and that you do receive the specific additional training in it. There's a lot that you learn from going through the trainings that you may not realize until you go through them, and a lot of support that you usually get through those trainings as well, because they have you do additional consultation throughout the course of most of those trainings. And that can be very helpful and help you feel more comfortable in being able to do the specific trauma work with your person. And in choosing a treatment to go with for an individual, it's very important to spend time getting to know your person that you're treating. You may do that rather quickly and have an idea of what would be helpful for them, but it may take time to build that therapeutic rapport with somebody to know which direction might be the most helpful for them. Sometimes identifying going straight to a trauma work can be too much for our person. So we have to pace our work at the pace that's right for our person that we're treating. And at points too, we may not be the ones who is the right person because we don't have the specific training in the therapy that would be the most beneficial for them. Or maybe a more medical-based intervention is right for them. So we have to be open to remember that it is important to be able to offer referrals to the appropriate sources and to get to someone who can be specialized in those areas. It's not about trying to force our patient or not to see our client or our patient, but to make sure that they're feeling like they're being helped without feeling like they're being abandoned. So some other factors to consider when you're looking at treatment is if it's childhood versus adult onset of a trauma that has occurred. So with that you look at how long maybe a person has experienced their trauma. It may have been a single event. It may have been an event that happened over multiple years of their life. And then also, if we factor in how long it has impacted their life, can be an important aspect to assess for as well. A person who has had a trauma, a one-time trauma in the last year, that may have had a smaller length of time impact on their life versus somebody who experienced a trauma maybe much younger in their life, say at age 6 and they're now maybe 30. That's almost 80% of their life that was possibly impacted from a one-time or even multiple-time trauma that occurred for them. So sometimes it's not just the experience themselves we need to look at and how impactful that was, but even the length of time this has impacted a person's life. So again, you'll see that I'm continuing to push for a continued assessment for people. Sometimes we miss out on that. We miss factoring that in, even to just our every time that we meet with someone, just continually looking for, hey, is there any other questions that I should be asking this time, and get that assessment process continually going. And in time, you will get to the core issues for your person that you're working with. So if there is trauma that they're wanting to be able to discuss with you, in time, they will get there with you, but they may need that time with you too. So always keeping in mind how we're doing that is an important factor. We don't want to feel like we're alienating anybody from talking with us about certain topics either. So it is very important when we're looking at what type of trauma treatment or any type of treatment we're doing with somebody is the therapeutic alliance. Research has shown how important therapeutic alliance is when we're doing any type of work with somebody. If our person that we're working with doesn't feel like they can talk to us and trust us, they're not going to be able to get as much help from us as they possibly could. And that's usually an in-time process. So, and also remembering in those factors for a person of resiliency and post-traumatic growth that can occur for them. So when we do finally get to working on some of that trauma, seeing all the good that can happen from doing that trauma work is a very important thing for us as providers to remember, that this can have a really positive impact if they're able to work through some of this and why we're doing this overall for them in the end. So having that process is very important throughout. So some of the impacts that we look at when we talk about having trauma impacts is, especially when there isn't proper treatment available or sought out, that the possibilities for further functioning impacts greatly increases for our people that we work with. We have seen, and statistics have shown, that there's usually further mental health impacts and other diagnoses, and you'll see individuals have usually a longer and longer list of other diagnoses added into their differential diagnosis, where really if we got to our core and worked on what that trauma was, that maybe we could help out a lot of the other symptomology as well. Probably not resolve it all, but very much maybe give some help in those areas. We also see the rates for substance use greatly increase. When you look at this ACEs study, so the adverse childhood experiences studies that are out there, we can see very easily that a rate for a lot of these for substance use, mental health, other medical issues, all of these greatly increase with the number of adverse childhood experiences or even traumatic events that somebody has experienced. So that's why it's important that we are assessing and getting into the treatment factors for them. Another area that we see is that without proper treatment and work for someone, that there is a further more easy rate for victimization or re-victimization to occur for someone. They may not realize how much of an impact that has had in their life and how that factors in for them. So that's just a start and a little bit of an overview of some trauma-related concerns and issues that we might see, and some considerations you might want to have, especially when working with adults and throughout the course of their care, whether you're working as their case manager or whether you're working more as a provider and as their therapist with them, just different things that you might want to have as a consideration in treatment. And from here, I will pass it over to Casey to discuss some further things about substance use.
Okay.
So the correlation between trauma and substance use, research identifies trauma as a significant contributing factor to substance use and addiction patterns. Current research shows us that traumatic experiences, especially in early life, can create a greater vulnerability to developing substance abuse problems. Trauma is a risk factor in nearly all substance use disorders. Decades of research have found a strong correlation between exposure to traumatic events and substance use disorder. Certain life events and environments make both disorders more likely. On the other hand, individuals with substance use disorders are also more likely to experience traumatic events, leaving millions of people in a continuous cycle of traumatic experiences and increased risk for abusing substances. It is imperative to note that it's not only individuals with a diagnosis of PTSD who experience substance use disorders. Merely the experience of a traumatic event can outcome an increased risk for substance use disorder. With some statistics, 75% of women and men in substance abuse treatment have reported a history of abuse and trauma. 97% of homeless women with mental illness report severe physical or sexual abuse. 12 to 34% of individuals in substance abuse treatment have PTSD. About 1/3 of people exposed to trauma develop PTSD. Men report higher incidences of trauma, but women are most likely to develop PTSD. 1/4 to 3/4 of people who have survived abusive or violent traumatic experiences have reported problematic alcohol use. 1/10 to 1/3 of people who have survived accidents, illness-related, or disaster-related traumatic events have reported problematic alcohol use, especially if they have experienced persistent health problems or chronic pain after the event. Men and women who have experienced sexual abuse have higher overall rates of alcohol and other substance use disorders. Most veterans have met criteria for substance use and PTSD diagnosis. The National Vietnam Veterans Readjustment Study conducted in the 1980s reported 74% of Vietnam veterans with PTSD also have a substance use disorder. For screening and assessment, so no screening or assessment of trauma should occur when the client is under the influence of alcohol or drugs. Clients under the influence are more likely to give inaccurate information. Individuals who are in a substance use disorder treatment should be screened for traumatic events and for trauma-related symptoms because this could affect their recovery. Discussing trauma can be challenging, but providing screening in a trauma-informed manner will help the therapist and the client develop a common understanding of the connection between their trauma and substance use. Possible overlapping signs and symptoms of trauma and substance use are depression, anxiety, mood swings, nightmares, negative thoughts about life, social isolation, irritability, loss of interest, hopelessness, and changes in behavior. So treating trauma and substance use. Those with co-occurring substance use disorder and trauma disorders have had poor treatment outcomes. Previous treatment modalities attempted to separate the treatment of substance use and trauma disorders, concentrating on one disorder at a time. The higher at rate which these two conditions occur, as well as a better understanding of how trauma affects the risk for substance use disorders, has led more mental and behavioral health organizations to promote the treatment of both disorders together. In the past, it was common to treat PTSD and substance use disorder separately. In fact, the substance use disorder was often treated first, and the treatment of PTSD would be put off until the person was sober for a period of time. Treatment courses have changed recently in which that integrated model of treatment is used to address both the substance use disorder and PTSD at the same time. The person may see the same clinician for both treatments rather than seeing two separate professionals. This approach helps address the complexity of symptoms since they may overlap. The person can address triggers and emotions connected with their substance use, which can help foster and maintain recovery. The ability to treat both the substance use disorder as well as any underlying trauma that could be contributing to the disorder has shown positive effects in client treatment. Applying components of the trauma-informed care framework can only benefit those who are struggling with substance use. So providing safety, choice, collaboration, trustworthiness, and empowerment with a client treatment is essential. Individuals who have trauma are more likely to develop a substance use disorder, and it can make it harder to get successful treatment for the substance use disorder. This is occasionally referred to as a self-medication hypothesis. So this is when people with trauma sometimes abuse substances to cope or self-medicate. However, even the substances make things much worse in the long run. Some therapeutic techniques, CBT, seeking safety, which is a present focus therapy that helps clients attain safety from trauma, including PTSD and substance abuse by emphasizing coping skills, grounding techniques, and education. Prolonged exposure, building self-worth, psychotherapy and medication use together should be considered. And there's just the sources that you guys can look at afterwards. And then I believe it's Elizabeth's turn.
Elizabeth, are you still with us?
Yes, I'm here. Can you-
Okay.
Okay.
Oh, nice.
Just to get started, there is a lot of really good research and studies that have tried to define and differentiate the symptoms between post-traumatic stress disorder and trauma and traumatic brain injury and psychosis. And within that research, they've seen quite an overlap in some of the symptoms and cognitive changes, but not only an overlap, but an interactivity between the experiences of trauma and psychosis and traumatic brain injury. Also, it's important to recognize that sometimes it's not either or, it's a combination that a person may have actually be experiencing all three. You know, they can experience trauma, they can experience a traumatic brain injury, and at the same time experience psychosis. And in fact, there's an interesting study that states that when they studied individuals with a predisposition for schizophrenia and their families, they said even with the families that did not have an individual that experienced schizophrenia, they were often predisposed, it seemed, to experiencing traumatic brain injury. So I'm not sure what that correlation means, but it's an interesting observation. Also, with individuals that have experienced traumatic brain injury, they have found that people that had post-traumatic stress disorder reported an increase in sensory type and cognitive changes than the individuals that just had traumatic brain injury alone. So there's some more interesting information. I placed some references in the PowerPoint at the end in order for you to kind of research more in depth. But for the overview, the overlapping symptoms are short-term memory. And you can kind of think of at times when someone's experiencing trauma and they have a traumatic brain injury, they're often searching for the source of the problem or trying to recall or be able to regain function, which wants them to remember information. At the same time, they're trying to forget information. So there's a dysregulation there, along with the emotional, sometimes dysregulation. And oftentimes there's a difference with the focus and the attention. Is it hypervigilance? Is it distraction? is the person thought blocking because of hallucinations that they're experiencing? Or it could be a combination of those things. So we looked at the focus, the concentration, sorting out those thoughts. And then, of course, we'll talk about the frontal brain that tries to put it all together and enable that person to plan, which makes it difficult. Okay. The next slide. Okay, so the possible overlapping triggers of a sense of uncertainty, things that are in place, unexpected, the waiting and timing, and isolation. All of those tend to be a theme of triggers in all three of trauma, of psychosis, and of trauma, psychosis, and traumatic brain injury. Those can be triggers that you're looking for. So if you see a person going through those, when they're sharing an experience, look at those and just observe those. Okay. They have changed with post-traumatic stress disorder and trauma. Sometimes they see a change in volume of the hippocampus and their ability there to regulate and take in information of emotion. The amygdala, medial prefrontal cortex, which is basically they're trying to is the area of the brain where you're trying to regulate your thoughts and your feelings and emotions as it relates to your goals. There's changes in with both post-traumatic stress disorder and in psychosis. There's changes in your neuroendocrine system. There's changes in neurotransmitters. So there's actually some neurological basis for some changes, for some interactivity between both psychosis and trauma. All right. When you're looking at the overlapping of symptoms, sometimes, again, you're looking at, is it arousal and hypervigilance due to the trauma? Is it, and when they have that response to the trauma and that hypervigilance, does that trigger the paranoia and triggers the voices? So then you have that interactivity. Emotional dysregulation it can be in both with trauma and traumatic brain injury. And then also with that emotional dysregulation trigger auditory hallucinations or suspicious thoughts or questioning that may happen in psychosis. There may be a hyper meaning that you place in details. Oftentimes with triggers with trauma, a detail may have a different meaning or an additional and more intense meaning. And that's often common also with delusions and psychosis. There's a hyper meaning and there's a value at place. Oftentimes, an individual that we see, for example, who experiences delusions may have a theme when they're talking about their experiences. It may be their lack of control or their lack of privacy or their invasion of their personal space. And you may see some reactions or increase in psychosis type of experiences when they hit the triggers that are also related to the trauma. And then with traumatic brain injury, sometimes when a person has had trauma prior to the traumatic brain injury, it fragments and changes the way that person may process the trauma. And that trauma of the traumatic brain injury itself may trigger the emotional and dysregulation that they may have experienced with the psychological trauma in the past. So and with that, at times that can trigger that fragmentation and thought and emotion can trigger a psychosis. And so there's some literature about post-traumatic stress disorder and status post-psychosis. And there is also some literature about traumatic brain injury and psychosis. All right. Wanted to touch just a little bit about individuals who experience psychosis and experience delusions. Oftentimes, when you look at a delusion, we're also taught that delusions are false beliefs. And we want to say, well, if the delusions go away, the patient is better. And hopefully with time, we understand that recovery isn't just a loss of symptoms. Recovery is being able to move forward with their goals. So in any times, whether a traumatic brain injury or trauma or psychosis, a person wants to maintain their sense of self. And it's important to recognize that that's what the brain is trying to do. It's trying to maintain its sense of self, maintain its self-concept. And with that, when you look at delusions, not to disregard the belief just because it's false, but to actually listen to their story, even if it's fragmented, and not to jump to conclusions or to jump into the therapist actually trying to find hyper meaning and try to make sense of the delusion, but just to observe. You want to be there with your patient and just to observe the speech that they're given, their experience that they're sharing, because as you do that, it decreases the stress to be defensive, to try to prove the delusion, and allows them to use the delusion as a structure in which they're trying to convey something. And within that, some pieces of reality, and they may even shift to full reality speech once that rapport is established. So the three bases here that often seen in delusions is that there's usually some small details of that delusion that is true. And there's also a theme, and the theme sometimes that you may see is has their privacy been invaded? Is there a sense of control? They're trying to maintain control or feel controlled. Are they trying to gain respect? Are they wanting someone to just to listen and to be able to be heard or seen? Do they feel someone's monitoring them or judging, or is their safety at risk? So those are all themes that, even though the delusion may not be accurate, the theme of the delusion is carrying some very important, very accurate information, because the feelings are real, even though what they say may not be completely accurate. What happens is the connection, where you find the hyper meaning, connecting that's where they may have trouble. And once that connects, it's almost like a knot that's very, very hard to undo. So you're helping them work through that structure in which there's that one meaning and belief that they're filtering everything through. So being with them as they're working through that structure is important, that you're not jumping ahead, or you're not negating, or you're not just saying, well, let me have them stop thinking about the delusion. If they don't think this, then they'll be better. Kind of want to get off that focus and focus in on the meaning. Okay. What may help in doing that and working with individuals with who experience all three of trauma and psychosis and traumatic brain injury is the cognitive therapy approach. It allows you to be there with your client and observe with them. And what you're doing is helping them along and recognizing and organizing their thoughts, their feelings, and actions. Just as they're talking, being able to do that and have them share with them that and teach them how to do that. You're looking at the here and now, and they're going to be able to notice and be able to possibly see their experience once again in a different light, because you're just observing it. You're not trying to recall it, which is going to interfere with self-regulation sometimes and interfere with short-term memory. You're trying to work on that experience in the here and now. And so the cognitive behavioral therapy approach is really good. you want to validate their experience, whether it's a false experience or they're in a psychosis. That's what they're experiencing. So once you validate that experience, you're validating what they value and you're validating what they're going through, and then you're bringing reinforcing that self-concept where you have those strengths. With that, self-affirmations are, they've done studies where self-affirmations help in predicting the future. So with anxiety and trauma, and you're hyper vigilant to what may happen, or you're afraid voices might start again, or you're paranoid, the self-affirmations will reinforce that self-concept. And when they do, when you feel a stronger self-concept, more capable, then there's less risk that you're going to see the future as a threat. And that sense of threat is what often gets triggered in psychosis, and also gets triggered in trauma. So and then can interfere with trying to self-regulate emotions that can be difficult for individuals with traumatic brain injury, with frustration tolerance and emotional regulation. So cognitive restructuring is validating the experience and then looking at how you want to approach it and what you're going to tell yourself during that experience that's going to be helpful. Okay. I placed on here an index card. Sometimes when people are working through experiences, they may have more than one familiar experience with the same type of theme. And as you start talking to them, you can go one by one with each experience and have them tell you in their format, whether it have delusions or hallucinations or some disorganization. They tell you in your format, and you place it, you write it all down, then you put it on index cards. And it sounds simple, but when they see it again, then they're able to edit it. They're able to take out a frame, so to say, and they're able to correct it or give more information, or at times say, is this really pertinent to my life? Is this pertinent to my story? Did I want it in here? Or was that a distracted thought or an intrusive thought? And then you can reorganize their story and they can see it again. And it's at that time that they can see it in the here and now, where they're able to take the healthy person now and be able to reconstruct and maintain a more reality-based and healthier concept of their of the bigger picture and of themselves.
Elizabeth, there's just a quick question in the chat if you have a moment. So someone was asking do you know if it is easy to determine if memory problems such as forgetting how to get home sometimes is occurring because of TBI and PTSD without TBI or PTSD without testing?
Okay.
I guess the question is about how do you, how do you determine the cause of some of these symptoms since there's overlap?
Well, to understand that there could be an overlap, so I'm never against additional testing that gives more information, as long as your focus isn't on necessarily just identifying the symptom. It's understanding how that person, what they're going through, what their experience is. For example, the timing of that. If they get lost at a certain time, then I would ask them to share with me an actual time where they got lost between home and where they were going. Was that related to the question? Did I hear it right?
I mean, she says yes.
Okay, yeah, it's the timing. And that's oftentimes when you think of it, they're sharing with you one experience, but you want them to see if they can share that experience in the here and now and then give you an example of that. And timing of when symptoms happen, that's really, really important. And they can tell you, what were you thinking at the time? What was happening right before that? And then you could see if there was possibly some triggers. Hope that helps. But most of the professionals and even if you look at that, there's several complications in defining what's the symptom of the trauma, what's the symptom of a neurological other type of problem from a brain injury or memory problem. So there is definitely some complications. Okay. All right. So I have time for the last slide. Okay.
We've got about 8 minutes left. So yeah.
Okay. All right. I kind of referenced this a little bit earlier is the therapy, when you're doing therapy, you don't want to lead to the person. It's sometimes you're having a cognitive conceptualization of what's happening, and you'll possibly think, hey, there could be trauma here. And we have to recognize that we're in an experience where we're therapists that see a lot of trauma, and we might be, oh, it could be this. So we've got to make sure we don't do the same things we're trying to help our patients or our clients not to do, not to jump to conclusions, and not to get to a point where we think something is and lead our patient there. We really want to stand almost side by side, metaphorically, with our patient to see that situation, so we don't make false connections, just like some of our patients may do with delusions. Okay. All right. There is a balance with following the thoughts, feelings, and actions. Sometimes you'll have patients that are experiencing a psychosis that will be able to participate 100% in that and kind of fit right into being able to say, this is how I felt and this is what I did. There's other times when someone is in rapid speech and flight of ideas. Well, you're just going to be writing it down and occasionally indicate how did that, what emotion did you feel at that time? And you're actually organizing it as you're writing it. And I actually share it with my patient, because I always, if you have a person that's prone to have some paranoid thoughts, you want them to make sure, hey, you can see whatever I'm writing. And when they're able to give them their own, make sure they have their own paper and pen so they can identify what they think and how they feel and what they do. Then you look at the timing of those things and then what they want to do when that experience happens. What do they want to tell themselves? So even if the therapist and the client may not agree on the source of the problem, whether it's delusional or in a psychosis, they can agree that it's interrupting and interfering with their life. And that's where you can connect. And you can also connect on those themes of those values of control, of respect, of privacy. And also recognize when, hey, this happened when something was unexpected. This happens when something seemed out of place. So you can kind of connect on those triggers and those values without getting centered on the actual content of that delusion and getting stuck on that. I guess I'll leave it time for any questions. Charity, back to you.
Thank you all. So if folks have questions, you can feel free to type them in the chat or unmute yourselves and just go ahead and ask. We've got about 5 minutes left.
I will also add in that where we work, because we all work at William R. Sharp Jr. Hospital, that we see our patients have a lot of trauma histories, along with many other possible things going on for them. So we see a lot of other diagnoses as well, but there's a consistent level of some trauma that's occurred for a lot of our individuals, just different types of trauma. So that's why we bring up this topic as a presentation day and heavily push for assessment and being able to work with your person and building that therapeutic alliance with them.
Great. While we're waiting for folks to see if they want to type stuff in the chat, I actually had a question for you, Charity, in your section where you talked about some of the anxieties and fears that providers might have around asking about trauma. You know,
Yes.
is there, do you have sort of, I'm trying to think how I want to phrase this. What are some sort of ways or techniques or sort of assurances maybe that you could provide for folks that are struggling with some of those worries? I know you talked a little bit about some of them, but.
A lot of what I found, because before I started in myself on doing work with trauma, I never wanted to do trauma related work because I was afraid. And I learned that a lot of my fear was because I didn't know what to do. So as I got further education in the area, I learned that there's ways that I can help, and that made it a lot more comfortable. And even ways if I can't help, that I know others can help, and I can get those referrals going to other people, but that there isn't just one right answer, and that just being present with my person is the most important factor for them whenever they're discussing any event that's happened for them, whether it's trauma related or not. But learning how to be present in that moment for them, and then learning from there how I can help, or how I know that there's other things that can help, even if it's not me. That helped a lot with being kind of nervous and fearful of what to do and how to ask some of those questions, because there's a lot of work that I don't specialize in. And that doesn't mean that I avoid asking questions about it. It just means that I need to know that there's other help out there too. And just because I don't know the answer, or I don't know if maybe something even needs to be reported or not, I can call people and ask. I'm never alone in the work. And that doesn't matter if I'm doing my own practice or anywhere else. There's always a phone you can pick up or someone you can find out answers from. And that's been the most helpful.
That's a great suggestion and point. Thank you. Does anybody else have questions? We do have a couple minutes left. Oh, here's a question. How do you phrase referrals to your clients without making the clients feel scared or passed along?
I can say when I've made referrals for clients, I talk with them about, what kind of things I'm noticing for them, what kind of treatments might be helpful for them, and then what those different treatments might mean, and that I am not the one who specializes in all those treatments, and I'm not trained in providing all of those treatments. But it doesn't mean that I can't find them the right person who may be, and help them look for those sources. And I can always be there for them in between, or in times when they've completed that treatment, or if they're finding that the person that they referred to wasn't the right fit for them. It doesn't mean they can't refer back to me and I can't help them further. So letting them know that they're still not just being dropped off, but that there's always availability to come and chat with me or ask me those things too.
Great. Any final questions? We are almost at time. So if you have a final question, go ahead and type it in the chat. I do, so people may have seen that I posted a link to the evaluation survey. So if folks have a minute, we invite you to complete that before you leave. If not, you can, we'll send you a link in the email that has your CE certificate. So I want to thank you guys for this presentation. It was terrific and very relevant to social work practice, and just and I appreciate that you covered multiple areas and intersections. So that's really great. So I'm not seeing any more questions. So thank you. Thank you everybody who attended today, and keep your eyes out for more announcements for future social work lunch and learns. And thank you to all of our presenters. It was a great job today.